Hello, I'm Dr. Lee. Welcome to the Practical Pain Management. In this video clip, I'm going to introduce MRI Anatomy and Ultrasound Guided Intervention. Learning MRI images is an excellent way to understand coracohumeral ligament anatomy. MRI shows fantastic pictures that are not covered by an ultrasound image. It is challenging to depict coracohumeral ligament with an ultrasound image. There are three directions of MRI scan. I prefer sagittal T2 scanning with fast saturation because it is very sensitive to pathology and shows the whole picture of the cut section of coracohumeral ligament. In the sagittal image, I'm going to subdivide it into central, middle, peripheral coracohumeral ligament. In identifying the pathology, I'll describe the signal intensity and thickness. Axial and coronal T2 weighted image would provide a supportive image. This MRI is sagittal T2 weighted images. This direction is anterior and this direction is superior. This MRI shows the normal signal intensity and size of coracohumeral ligament. Coracohumeral ligament is low signal intensity but a slightly brighter signal intensity compared to the dark signal intensity of the biceps tendon. Let's take a closer look. Peripheral coracohumeral ligament is noted under the deltoid muscle, superficial to the biceps tendon, and it is flat and low signal intensity. Middle coracohumeral ligament is located under the deltoid muscle, just the lateral edge of the coracoid process. It is located anterior superior to biceps tendon, and it becomes a thicker and rhomboid shape and mixed signal intensity. Central coracohumeral ligament is located under the coracoid process and anterior superior to the biceps tendon. Signal intensity is similar to middle coracohumeral ligament. In summary, coracohumeral ligament is not attached to the lateral edge of the coracoid process but attached to the inferior surface. Coracohumeral ligament is not flat tape-like structure. Central portion of coracohumeral ligament is thicker than the peripheral one. In T2 weighted image, its signal intensity is low but brighter than biceps tendon. And according to the histology specimen, the ligament consists of irregular and sparse fiber, so it is not a typical genuine ligament structure. Inflammation and fibrosis of coracohumeral ligament are some of the most common findings of adhesive capsulitis. In my experience, we need 3 Tesla MRI to detect a minor change of ligament content signal, and low Tesla MRI is not sensitive to detect the signal change of coracohumeral ligament. I want to categorize the pathologic area into diffuse or localized type. This is the case of diffuse type. Swelling and high signal intensity are shown in peripheral, middle, and central coracohumeral ligament. These are coronal T2 weighted image and axial T2 weighted images. Coronal and axial T2 weighted image shows diffuse high signal intensity in the entire course of coracohumeral ligament. In this patient, swelling and high signal intensity are shown in middle and central coracohumeral ligament. Axial and coronal T2 weighted image shows localized high signal intensity in the central aspect of coracohumeral ligament. In this patient, swelling and high signal intensity are shown only in the middle coracohumeral ligament. Coronal and axial T2 weighted image shows localized high signal intensity in the middle aspect of coracohumeral ligament. What are the common MRI pathologic findings of adhesive capsulitis? Edema and high signal intensities are found in many areas of anterior and inferior capsule. Coracohumeral ligament is one of the prediction sites of pathology involvement of adhesive capsulitis. I always include the coracohumeral ligament as one of the injection sites when I found pathology in the coracohumeral ligament. Please read this article. I agree with the author's opinion. The surface landmarks were drawn on the surface of deltoid region, acromion, coracoid process, biciptal groove and biceps tendon, and corresponding ultrasound image. My needle approaches the coracohumeral ligament from lateral to medial toward the upper edge of a coracoid process. Let's take a closer look at the correlated ultrasound image. 1 is the level of a biceps groove. 2 and 3 shows intra-articular portion of biceps and coracohumeral ligament. 4 and 5 show anisotropy of a coracohumeral ligament. This part is difficult to watch the ligament, so many pain practitioners are unfamiliar at this level. My needle aims the coracohumeral ligament toward the upper edge of the coracoid process in adhesive capsulitis, but it has to change to the type of pathologic involvement. This image shows the process of ultrasound guided procedure. My needle approaches from lateral to medial toward the coracohumeral ligament at the level of superior edge of coracoid process. I put in MR contrast media during the procedure, and it proves that the contrast media spread well to the coracohumeral ligament and subacromial space. Let's go to my operation room. To open up an extension of the coracohumeral ligament, rotate the patient's arm externally. Before the injection procedure, I need to thoroughly pre-scanning the target and adjacent structures. I use an aseptic lubricant mixture of aqueous chlorhexidine, alcohol, and chlorhexidine cream. Let me explain ultrasound anatomy. Surface echo of coracoid process, articular surface of humerus head, anisotropy of coracohumeral ligament. Triangular echogenic structure is a middle coracohumeral ligament and lateral part of central coracohumeral ligament. You can find the expanding coracohumeral ligament by injecting fluid. Thank you for your attention.